A very good morning to all, and thank you for the opportunity to share our work. Our paper is on the spectrum of microbial keratitis during post-COVID convalescence. We report the clinical and demographic profile of microbial keratitis in patients who presented within 3 months of acute COVID-19 infection. We had 18 eyes of 16 patients with microbial keratitis during the post-COVID convalescence. 14 patients were unilateral. We had an IRB approval for the study. The presentation was between 1 to 93 days post-COVID. The risk factors were multiple. There were more than one risk factor in each patient, so the total would add up to be more than 18. However, the commonest was the hospitalization for COVID. In addition, there were comorbidities such as diabetes and hypertension. Oxygen administration and systemic steroids are also administered in 5 and 3 patients respectively. The microbes that we identified were equally divided between microsporidia and fungus, the other two being a case of pythium and herpes zoster. We managed these cases medically in 9, but therapeutic keratoplasty was required in 5, and tissue adhesives with bandage contact lens was administered in 2 patients. I will briefly run you through 3 clinical scenarios. Number 1 was the microsporidia. Microsporidia keratoconjunctivitis is very common in our setup. However, what was different during COVID was that it had a component of anterior uveitis. So this was a young girl who was isolated with their parents, and the parents had COVID. This girl was not tested with COVID. Nonetheless, being in close proximity, this patient most likely had the symptoms of COVID and was treated as a COVID patient. And 2 weeks post the recovery, there was stuck-on lesions on the cornea. But what was special was that there was anterior uveitis and there was pseudogatati on the cornea, which resolved with fluorometholone after the corneal lesions resolved. This was the second case of an atypical fungal keratitis. So this patient was hospitalized. There was neurotrophic keratitis, exposure keratopathy, and post-infection, the patient after hospitalization of 5 days presented with a neurotrophic keratitis and a secondary fungal infection. So in addition to antifungal, this patient also required tarsorrhaphy and amniotic membrane graft. This was a third patient of redness, watering, and swelling, and this patient had herpes zoster sign herpet. He was hospitalized 3 weeks earlier and was on IV steroids. Oral acyclovir 800 milligram helped with resolution of this condition. So perhaps these are patients of long COVID, which is a symptoms of COVID within 2 months of convalescence. And these patients had a dropout of the nerve vessels as was shown in this study. So perhaps there is a decrease in the nerve density and increase in dendritic cells. And though we cannot particularly suggest a causal association, but there might be a temporal association with COVID convalescence, and altered immune response leads to this altered manipulation. So thank you very much. I would like to acknowledge the help of colleagues and fellows who helped in collate all this data. Thank you.
Good. One thing, what was the mean time between the COVID and presentations?
Typically, we saw them within 3 months. The range was 1 to 93 days, but majority of the patients were within 2 weeks to 4 weeks of the post-COVID convalescence.
And it's interesting, no bacterial keratitis.
Yes, that was something which is very surprising. And in our part of the country, microsporidia keratoconjunctivitis is very common. There are a series of publications. But microsporidia keratoconjunctivitis, unlike the adenoviral keratoconjunctivitis, is typically a stuck-on lesion on the cornea, and the anterior segment is absolutely normal. Whereas the COVID patients typically had a component of anterior segment inflammation. And these were PCR positive microsporidia, meaning that we thought that we could be mistaken. So what we did was that we scraped and then subjected this to pan microsporidia RNA, and also the adenoviral DNA, and it came to be positive for
Positive.
PCR.
Because there are a lot of reports also.
Yes.
COVID virus also breaks down blood aqueous barrier.
Absolutely, yes,
That's
yes.
the reason.
Certainly, this is the interesting thing about the study.
All right.
Yeah, I think very interesting, as you yourself pointed in your last slide, that the causal association, it's difficult to prove that. The fact that it's bilateral, of course for microsporidiosis that's pretty common, but for fungal keratitis to get that bilateral,
Yes,
it is very uncommon. So
indeed,
yeah,
indeed.
yeah, it's quite a good presentation. Thank you.